Hello, good morning, good afternoon, good evening everyone. Welcome po sa ating very first webinar of the year 2023. Happy New Year po as we start our season 11. Thank you rin po for being part of our credible online community. At hindi nyo po na itatanong, this is our 130th webinar po. And for all those who have just discovered us for today, welcome po. Sana po mas masayahan po kayo at marami po kayong matutunan sa ating topic for today. For our webinar for today, we ask ourselves, should menstrual pain really be part and parcel of the female experience? Most women have just resigned themselves to this fact, but should that be the case? The Philippine General Hospital is observing an increase in the number of women consulting for pelvic pain, then diagnosed later on as endometriosis. Special clinics have been opened to provide services for these certain cases. Endometriosis, as you know, is a disease where tissue similar to the lining of the uterus grows outside of the uterus, causing pain and or infertility. Sa buong mundo po, it affects about 10% of women and girls of reproductive age. It is a chronic disease. It's associated with severe life-impacting pain during periods, sexual intercourse, bowel movements, and or urination, with other symptoms such as chronic pelvic pain, abdominal bloating, nausea, fatigue, sometimes depression, anxiety, and infertility. So for our topic po for today, we really will ask ourselves with regards to the topic on masakit po ba ang puson? Pwede po ba itong maging endometriosis? Dr. Raymond Francis Sarmiento, Director National Telehealth Center, National Institutes of Health, University of the Philippines, Manila. Always a pleasure to be with all of you during our Friday. So welcome po again mga ka-Fridays, and always looking forward to Fridays because I get to share hosting duties with my mentor, also our adjunct research faculty at National Telehealth Center, Dr. Susie Pineda Mercado. Dr. Susie?
Hi, Raymond. Happy New Year and Happy New Season to everyone. We really missed you. Ako nga, pag panahon na ng webinar, parang hindi ko alam anong gagawin ko kasi nasanay na ako. But it's so great to have everyone back and to be back with you. I'd like to greet all of those who are in the Zoom webinar right now and those who are watching on live stream through TVUP Facebook page and Stop COVID Deaths Facebook page. And of course, all those who are watching through the TVUP Signal TV channel 101, because we are on television aside from being on the TVUP webinar series. So in this episode, we will take a closer look at endometriosis, signs and symptoms, and consultation for pelvic pain. So we have our main presenter, the best. OBGYN infertility specialist, past president of the Philippine Society for Reproductive Medicine, Dr. Angela Aguilar. And our reactor is Dr. GLADYS TANANGONAN, who subspecializes in reproductive endocrinology and infertility, both from the Division of Reproductive Endocrinology and Infertility at the Philippine General Hospital. And for our synthesis and closing remarks, we have back with us Dr. Stella Marie L. Jose, the newly appointed head of the Expanded Education and Training Office of the Philippine General Hospital. Congratulations. Stella, palakpakan naman natin. Walang palakpak. O sige, okay. So, as you see, yun, may palakpak pa rin kay Stella. Okay, great. So, we decided to start with this topic because PGH was reporting more cases of pelvic pain. And, I wonder if you're seeing that in your practice, if you're seeing that in your hospital. So we're going to give you the latest on this. And I know you're going to learn a lot, so stay with us. But for those of you who are really looking forward to hearing about the latest news and developments in the field of medicine and health, we bring you the news update.
Okay, thank you so much, Dr. Susie, for our very first news update of the year. The World Health Organization announces plans to establish a tuberculosis vaccine accelerator council. So ito pong the adverse impact of COVID-19 pandemic on tuberculosis services. It really has brought the urgency of vaccine development efforts into sharp focus. So during the World Economic Forum na naganap po, no, that was announced by Director General Tedros of the World Health Organization, their plans to establish a new TB Vaccine Accelerator Council. So this council will facilitate the licensing and the use of effective novel TB vaccines to catalyze high-level alignment between funders, global agencies, governments, and end users para ma-identify po and overcome barriers to TB vaccine development. So abangan po natin yan at sana po ay talagang, well, it comes to fruition, especially in the next few months or maybe in a year po. Dr. Susie?
Yeah, thank you, Raymond. On another front also on vaccines, the only HIV vaccine in advanced trials has failed. So Janssen Pharmaceuticals ended a global trial after independent experts determined that the vaccine against HIV was not effective. But there are other possibilities in the pipeline, scientists say. So this new vaccine for HIV is something we have been waiting for many decades. It's known as Masakit, and it's a product of a public-private partnership, including the US government and the pharmaceutical giant Janssen. It was run out of 8 nations in Europe and the Americas, including the United States, and it started in 2019. However, after all of this research, leaders of the study decided to discontinue it after finding out that they did not see any evidence that vaccines lowered participants' rates of HIV. And that's our news for today. We'll be back next week with more news for you on the news update. Okay, and we're back. We are back to our topic. And there seems to be limited awareness about endometriosis. But, you know, we did a person on the street interview, and you're going to see it in a moment. I won't preempt it, but Raymond is going to cue it. Raymond.
Thank you so much, Dr. Susie. Especially for those po na very first time na sasali po sa ating webinar for today, we usually set our discussion into context by having our short video played po. No? And this is produced po by TVUP. We are asking questions po on the common folks on the street, which we call person on the street interviews. And the question for this week was, pwedeng normal lang po ba ang magdysmenorrhea o masakit ang puson? Please watch this.
In my case, a week before my first day, I do experience pain. It is dysmenorrhea and migraines. Usually, the pain on a scale of 1 to 10 would range from 4 to 6.
For me, pwedeng maging normal yung dysmenorrhea pag mild lang to.
Yes, dahil in my experience, tuwing nagkakaroon ako ng menstruation, it's very normal na magkaroon ako ng dysmenorrhea, most especially sa first 2 to 3 days.
It is a case-to-case basis, but as for me, I do think that it's normal because as much as possible, I try to understand and familiarize the things that's been going on inside and outside my body. Listening to our body is very important because it's only then that we get to know what's normal for us and what's not.
There are cases na the pain would be so extreme, reaching 8, 9, and 10. So on those days, I have to get checked sa OB-GYN. I was once suspecting endometriosis because of the pain.
Well, sa akin kasi, hindi naman every period sumasakit yung puson ko. Hindi naman ako laging nagdidysmenorrhea. Pero may mga kaibigan ako na kada menstrual period nila, nagdidysmenorrhea talaga. And may iba talaga na every month nagkakaroon.
And napapansin ko rin sa ibang mga tao, tulad ng my sister, bago lang siya sa world ng pagkakaroon ng menstruation, and she's also experiencing having dysmenorrhea or the menstrual pain tuwing nagkakaroon.
I get my menstruation regularly, and that being said, I experience dysmenorrhea every month. In my case, I understood that it's normal because my system is going through some chemical imbalances. That's why there's shredding, there's contraction in the lower abdomen.
So sabi nila sobrang sakit daw, as in hindi na manageable yung sakit. Tapos nung nag-consult na sa doctor, may tumutubo na palang mga maliliit na bukol sa ovary nila or may ibang komplikasyon na.
However, when I got checked, it was ruled out. It turns out I only have myomas, which is also the cause of the dysmenorrhea.
The pain usually peaks normally on the first and second day. After that, it's gone. I do try applying hot compress to ease the pain, and after that, it's totally gone. Therefore, I think yes, I think it's normal.
I think ang pagkaranas ng dysmenorrhea ay hindi lang basta-basta. And kailangan pa rin pakiramdaman yung sarili bago masabi natin na normal lang to.
Okay, thank you so much, TVUP, for that, and to all of those who participated in the person on the street interview. Nagpapasalamat tayo, no, that they're willing to share something very personal. Pero aalamin natin ngayon talaga, ano ba itong dysmenorrhea? Kailan ba dapat, when should you be worried about it? And I think it's something that affects a lot of women. So we are very happy to have our specialists today. But before we do that, Raymond has some housekeeping. Raymond, over to you.
Thank you, Dr. Susie, and thank you po to TVUP for our person on the street videos. A little bit of housekeeping with regards to the certificates po, which we continue to get questions po, no? Certificates of attendance will be given only to those who watch at least 50% of the webinar duration. You should be able to see on your screens po, no, sample of that certificate of attendance, e-certificate. If you did not receive any certificate po, especially for our 2022 webinars, webinar 129 down, please let us know by emailing us at stopcovidets@up.edu.ph. Dr. Susie?
Okay, so let's proceed with our topic at hand. And we're going to learn about, the misconceptions, the true and false around dysmenorrhea. And I think one of the issues that we were considering when we talked about this was because of the early lockdowns during the pandemic. Siguro maraming nagkakaroon ng sakit sa puso na hindi nila nakapakonsulta kasi mahirap pumunta sa ospital. So let's start. Okay, Raymond, over to you with our format for today.
Thank you, Dr. Susie. For our webinar for today, we'll be having a standard panel discussion format. After our main speaker has presented, we will hear from our reactors, and this will be followed by a Q&A session. But before that, before we delve right into our webinar, very excited po kayo. Alam namin po na sa aming fun quiz. So ito na po ang cute intro video sa ating fun quiz segment.
Hello? Hello? Hello?
Kumusta na kayo lahat?
Hi, I'm Doc Susie, the mini Doc Susie.
And I'm Doc Radar, the mini Doc Raymond. Are you ready to have fun? Simply open your browser to www.slido.com and enter your code to participate. We will discuss your answers during the panel discussion later on in the program.
We will have it flashing on your screen in a bit, and we look forward to your answers. Masaya at madali lang ito. Join na!
Uy, bago.
Ano ba yun? TVUP, pinaglalaroan tayo Year of the Rabbit. Okay.
The bunnies. Matagal pa naman ang Easter Bunny.
Oh my goodness. Okay.
Okay po. Thank you so much. Today, we have two questions. They're right in front of you. So, for those who are outside of the Zoom, watching us in YouTube or in Facebook, please open up your browsers, type in slido.com and enter the code 65100996. That's 6510096 for you to be able to participate in our fun quiz. For our very first question, kung masakit ang puson, kailan dapat kumonsulta sa doktor? Is it A, palala na ang sakit habang niregla? B, hindi mabuntis? C, hindi tumitigil ang pagdurugo? Or D, all of the above, lahat po na nabanggit. I'd like to take this opportunity to greet those who are joining us from the St. Marina Kidney and Dialysis Center in Vigan, Sumajit Salamida Eye Clinic in Roas Isabela, St. Francis Cabrini Medical Center and Cancer Institute in Santo Tomas, Batangas, the Mayor Hilarion A. Ramiro Sr. Medical Center in Osamis City, Misamis Occidental, Cagayan de Oro City Council for Protection of Children, Misamis Oriental, Cagayan de Oro. Those who are watching us from the UP PGH Ward 1, maraming salamat po. From Isabela, those who are masugid na tagapanood po from Los Baños, Laguna, maraming salamat po sa inyong pagbabalik. Schools Division of Isabela, Regional Office of Tuguegarao in Region 2, thank you so much sa ating avid viewers, si Sir Joseph. From the University of Rizal System, thank you so much. Amang Rodriguez Memorial Medical Center, Public Health Unit, Health Education and Promotion Office in Marikina City. And those who are really very much in tune po. Happy New Year po sa inyong lahat. Doon po pati sa National Teachers College. Thank you. Camp General Emilio Aguinaldo Station Hospital. Maraming salamat po. For next question, question number 2. Namamana po ba ang endometriosis? Is it yes or is it no? Okay? We greet those also who are joining us from internationally, from the Chonin Hospital, Taipei City in Taiwan, Bangkok, Thailand, from Penang, Malaysia, University of Hail in Saudi Arabia, Unichi Ali University of Blida 2, Algeria, Stockton, California, Los Angeles also in California, and Toronto in Ontario, Canada. So maraming salamat po. We will not be closing this po muna, no? Kasi we know that you want to participate, but we'll move on straight up po to our main presentation for today. Dr. Susie?
Okay, thank you. You know, we really try to bring you the best possible speakers, and you're getting the best today. Our main speaker was the past president of the Philippine Society for Reproductive Medicine, also past president of the Pediatric and Adolescent Gynecology Society of the Philippines, and training committee chair of the Philippine Society for Gynecologic Endoscopy. And she's also the second country representative in the Asia Pacific Initiative on Reproduction, or ASPIRE. Talagang mabigat ang ating speaker ngayon at napakaganda ng presentation niya. We'd like to welcome Dr. Angela Aguilar. Angge, welcome!
Hello, good afternoon to everyone. Alam kong masyadong mabenta ang ganitong webinar. Okay, thank you to the TVUP, Ma'am Susie, and Doc Raymond for this opportunity.
Sige, go ahead.
So, we can share my screen already. Okay.
Yes po. Go ahead, ma'am.
There. So kindly give me a feedback if it is seen already.
It's up, ma'am. If you could go to slide presentation, slideshow.
There you
There
go.
you go.
Okay. Ayan.
Sige. So maraming salamat. So what we want is just a brief overview of what we need to know about endometriosis. And like our intro says, it's a very common condition, napakadalas, and it's worldwide. Look at this. Painful periods affect 1 in 10 women. And the prevalence rates of endometriosis in women with infertility is about 31%. In women with chronic pelvic pain, kung mayroon kang sakit sa puson, 1 out of 2 women will likely have this condition called endometriosis. Interestingly, in women without any symptoms, it is found incidentally in 23%. Now, we have a lot of studies worldwide, and it is shown that, interestingly, Europeans have a lower prevalence, 17%, compared with Asians, 36%. So what accounts for this? Is it genetics? Or maybe there is a greater access to care In women in Europe, there's greater early diagnosis or trying to rule out the condition when this happens. But for women in Asia, it seems that the prevalence is quite high. And in a general systematic review, they found out that overall, there's possibly about 7% of women worldwide, or as you say, nearly 1 of 10 will have this condition. So look at this typical case we saw recently in our institution, the Philippine General Hospital. Her case is quite common, 41-year-old without any previous pregnancy and having a 4-year history of pelvic pain. She had been married for 11 years, okay, with an 11-year history of infertility. And because of the workup for the pelvic pain, an ultrasound was requested and this was seen. There was a mass, and the mass was not just one but two bilateral cystic masses with this characteristic as described, and this is very typical of this condition. So let me launch into the topic of what endometriosis is, what we need to know, and what points is important for us to understand and to seek treatment if not managed, if we are even just primary healthcare physicians, all the way to gynecologists and subspecialists with regards helping women with this condition. So this is a short outline that I've developed. Where does it come from? How does it develop, this disease? How is it detected? What do we give for pain? And what about the cysts? How do we manage that? And how do we manage fertility concerns? So first of all, where does it come from? Is it a cyst of the ovary? Ito ba ay bukol, okay, na kailangan tanggalin? So interestingly, there are many phenotypes. So maraming klase, not just the ovarian cyst, but we also have two other phenotypes, namely the superficial endometriosis. These are implants in the peritoneum that may cause fibrosis and adhesions. And the last phenotype is the deep infiltrating endometriosis. This is postulated to cause the most amount of pain and is the most difficult to treat and may cause more problems, including ureteral obstruction sometimes, and even intractable bowel obstruction or bowel obstruction that need to be relieved by surgery. So the question was, namamana ba endometriosis? The answer is yes. There is a genetic predisposition to endometriosis. And if you look at this table, the table shows that there are genes commonly associated with the development of cancer that may cause mutations in an individual that changes the endometriosis or the uterine microenvironment that affect the life of the cells and affect how hormones such as estrogen, commonly found coming from the ovary, will change the growth, the dissemination, and the implantation of the uterine cells, otherwise known as the endometrial cells. When this environment is created by the genes as well as the hormones, you will see the sequelae. You have lesion, the endometriosis, the endometrial cells will implant, and in the surfaces of the peritoneum, the uterus, the ovaries, fallopian tubes. It may cause inflammation, leading to fibrosis, and it will produce the symptoms, pelvic pain, infertility, the gastrointestinal, genitourinary symptoms that is common with endometriosis. Now, how does it develop? We may have the genes, but where do these cells come from? So you see, there is transtubal transport of the cells. Transtubal meaning the cells coming from the uterine lining called endometrial cells are shed. This is a normal physiologic occurrence. Every month, lahat ng babae, all women who have menstruation will have this. Not all cells are shed with blood through the vagina. Some go back through retrograde menstruation, that's the term, through the fallopian tubes, and go to the abdominal cavity. Okay, but why do some women develop endometriosis, and why do many women not develop endometriosis? Again, this is the genetic predisposition that is aggravated, of course, by the inflammatory milieu. So when these cells go through the tubes and go to the peritoneal cavity, women with the predisposition have these cells implant. They not only implant, they multiply, they grow, and produce the sequelae. And this is the schematic diagram of how this works. So how is it detected? Okay, for many women, it is common to have the symptom of pain. However, pain is not, it's not conclusive that you do have endometriosis. There may be other conditions that may produce it. Hence, there is a recommendation for a workup of the cause of the pain. Before, endometriosis was diagnosed by a gold standard of surgery and uh, tissue biopsy. So, kailangan maoperahan tayo, kailangan kumuha ng parte ng cyst o ng mga implants at ispasuri sa microscope sa laboratory. But nowadays, what we're advocating for is the clinical diagnosis of endometriosis. Clinical meaning that there are certain symptoms and certain manifestations that are highly correlated with the disease if taken together. Why are we advocating for this? That is because the old gold standard, meaning tissue diagnosis obtained through surgery, not only is expensive, it is invasive, and it may cause morbidity by just mere performance. Okay, imagine you will have to go through anesthesia, you will have to go through a surgical procedure, even if it's minimally invasive, such as diagnostic laparoscopy, just to ensure that this condition is present. Not only is symptomatology a useful tool to diagnose endometriosis, we also have pelvic examination or physical examination findings that are highly correlated with this disease. We also have very good imaging studies that will almost always determine that the lesion that you have is indeed endometriosis. Our local sonologists are highly adept at diagnosing the disease, and when you go and operate eventually, then you will see a very high specificity of this diagnosis using all three parameters. So luckily, because clinical diagnosis and the other parameters such as pelvic examination and imaging studies are highly specific to determine that the patient has endometriosis, we now can give empiric treatment. Ibig sabihin, pwede nating bigyan ng gamot kung naniniwala tayo ayon sa ating pagsusuri ay ang babae ay may endometriosis. Ang pinaka-importanteng mabigyan ng solusyon ay yung most common symptom called pelvic pain. Okay? Yun yung napakadalas na manifestation ng endometriosis. Why do we have to recognize and treat this condition early? Look at the mechanism of pain of endometriosis. And for many women, this may occur as early as in the adolescent when the woman starts menstruating. And if it is unmanaged, unrecognized, and unmanaged, you will have continuous sensitization of the peripheral from nervous pathways from your pain receptors in the pelvis to the peripheral nervous system all the way to the cerebral cortex. And continuous stimulation of this pathway will produce chronic pelvic pain syndrome. And it may be so chronic that even if you remove all pelvic organs and all visible lesions of endometriosis, the pain has imprinted and you will no longer be able to just manage the pain with mere pharmacologic treatment. So you will have multimodality pain management. So we want to prevent that. We want to prevent the development of intractable pain. Luckily, we have very effective therapeutics for pelvic pain, and the medications are available locally in our setting. First line therapy, second line therapy, and you have third and fourth line if the woman is not responding. So for first line therapy, hormonal medications are our mainstay, and you will have simple medications such as combined oral contraceptives, highly available and accessible, as well as progesterone only medications, whether it's oral, it's parenteral, or it's implantable. We all have this locally and worldwide. Now, these medications are available and it's safe because the adverse effects even are minimal and it is well tolerated, and you can provide good pain control for a long period of time, because we have to keep the woman suppressed for the longest time, because until she reaches the menopausal age, where estrogen no longer stimulates the lesions, we really have to maintain the suppression because this condition is chronic and recurrent. Only when medications, the first line medications, not work, will you start resorting to second line therapy. Second line therapy, for example, GnRH analogs such as Leuprolide or triptorelin or goserelin, locally available as well, may be given only for a short period of time and then overlapped again with your first line therapy if there is somehow breakthrough pain management. However, for first line therapy, there are uh, hierarchy of effectiveness. For example, in our special interest group summary of evidence, we did a meta-analysis of randomized controlled trials, and we found out that there are progestin preparations here. You can see the images that are as effective as short-term medications as GnRH, are more effective than just pills, and is a lot better than just giving nothing at all or just NSAIDs or expectant management. So you have to make sure that the patient understands that there are choices from among the first line medications. Now, for third line therapy, for example, medical therapy fails, having tried 3 to 6 months and still you have uh, unmanageable pain, then we will resort to surgical excision of uh, the lesions that you see. For example, in our patient, we have ovarian cyst. If the patient is nearing the perimenopausal age and no longer desires of pregnancy, then you can remove all pelvic organs, including the ovaries, that will extirpate not just the lesions, but also remove the hormonal source of hormonal stimulation of the lesions. Now, uh, given that we can give medical management for pain, what do we do when we see the cyst? That's the most common question. Well, the cysts have to be evaluated first, no? If the pain is managed, we still have to contend with the fact that a cyst, we really have to make sure that it's a benign condition and we can adequately suppress the pain with just medications. Again, luckily, we have very good and highly specific sonographic or imaging studies that can correlate well with determining whether the cyst is benign or malignant. Here you can see that there are attributes for benign disease and there are characteristics for malignant disease. There are computations. For example, we have the IOTA adnex model that will tell you the likelihood of malignancy or the likelihood of a benign disease. And together with the patient, you'll be able to determine whether medical management is a better course, or because of high consideration of malignancy, then surgical management may be the option that we will pursue. So when you indeed perform surgical management, it is encouraged that minimally invasive techniques are to be employed. That is because open surgery may result in greater damage, most especially if you have adhesions that may develop post surgery. And the caveat here is that when you perform surgery in an endometriosis and uh, you did not remove the ovaries or the uterus, then recurrent disease is commonplace. 15 to up as much as 66% of women will have recurrence of ovarian cysts after the surgery, as early as 6 to 12 months from the time of surgery. So not only should you make sure that the cysts are well extirpated, or the lesions are well extirpated, we also should medically suppress again the patient uh, continuously until the perimenopausal age group. Now, for this patient, she's 41-year-old, she's a newly gravid. We had to ensure that the patient does not have any malignancy. Here is her tumor markers, an additional method of estimating the risk. And you can see that CA125, a tumor marker, is elevated. It's consistent with malignancy, but it's high, also elevated with cancer and endometriosis. So to improve the specificity of the tumor marker, we add another tumor marker, and that is HE4. The HE4 is highly specific for epithelial ovarian malignancy. This one is low, and adding another layer of determining whether this is cancer or not, we use the ROMA score, which is a combination of a CA125, the menopausal status of the patient, as well as the ultrasound characteristics. And it was determined that our patient was 4.2, has a 4.2 score, deemed as low risk. So the patient eventually underwent laparoscopic oophorecystectomy, also to evaluate her fallopian tubes, because we would want to also provide fertility care for this patient. With bilateral ovarian endometriosis, it is hard for us to monitor ovulation when we're trying to assist the patient towards her goal of fertility. Unfortunately, for this patient, male factor was noted. Look at the semen analysis. While the volume was normal, the sperm concentration was very low. It did not even reach 1 million. The normal concentration is 15 million per ml. The motility is also abnormal, very low at 9%. The normal is 40%. So for this patient, we need assisted reproductive technology and lecture unto itself to assist her towards her goal. But hopefully, we will be able to continuously suppress her until she's able to afford assisted reproductive technology in the form of IVF. So for these patients, how do we manage fertility concerns? This is the algorithm published recently, showing that for women with infertility, you look at the right side of the diagram, active management of infertility, not expectant management, should be employed for women with endometriosis. This consists of ovulation induction and intrauterine insemination. And if this fails after 3 to 4 cycles, then we proceed with in vitro fertilization. For our patient, IVF is already the next step because the male, the semen analysis does not lend itself to a pregnancy, a successful pregnancy, given the severe oligoastenospermia of the patient. So I'd like to summarize my talk in several sentences, but to allow you to be able to have a copy of the summary of the talk or the points that I have discussed, let me direct you to this article, which we co-wrote together with other experts in endometriosis, the consensus from our Asian expert group, and it is published recently again, volume 10, number 12. This is open access journal, and it will provide you with a very good algorithm from the evaluation of endometriosis to the early treatment and long-term management of this condition. So with that, if you need to have other information, you have any questions, or you also want to access a list of fertility as well as endometriosis doctors that can provide you with care, here is our website. Our organization is psrminc.org, and we would also like to invite you to attend face-to-face our 11th Asian Congress, and it is going to be held in Manila this September at the Marriott Hotel. So thank you very much, and I think that is my last slide today.
Okay, thank you so much. Galing naman ng presentation mo yun. Parang, anyway, I thought it was really, really great, very well presented, and the graphics were really so good and so easy, making it so easy to understand. Thank you. Ang guest stay for the open forum, baka may mga questions dyan. Okay, so let's go to Raymond's gonna introduce our reactor. Raymond, asan ka na? Uy, nawala si Raymond. We lost Raymond. Okay, wait, I need to open the... Okay, so let me introduce our reactor, and my notes are closed, but I know it's Dr. Gloria Tangonan. So welcome to the GLADYS Tangonan, also from UPPGH. So welcome, and please start your reaction. Sorry, Gladys, sorry. Go ahead.
So good afternoon, everyone. So I would just like to share a few slides. Not much of a violent reaction to Dr. Aguilar's lecture, but more of an adjunct. So I want it to be a practical answer to treating endometriosis. So probably one of the questions I would like to answer is that, does endometriosis increase susceptibility to COVID-19? So far, the studies have shown that endometriosis does not increase the susceptibility to COVID-19 infections, but alters the manifestation of the disease. And the prevalence of the disease may depend on the interaction between the virus and the individual's immune system, but further studies are required in this regard. So that's good news, actually. So the having endometriosis does not actually make us prone to have COVID-19. But what is the effect of COVID-19 now to endometriosis? So it's basically the delay in the treatment for endometriosis care. So the pandemic has greatly affected all aspects of medical care. And of course, the focus during a pandemic would be to treat the COVID-19. And this means people with other conditions faced barriers to accessing medical appointments, prescriptions, and procedures. There was also delay in the appointments and in the surgeries that were needed to treat endometriosis. So these were all discussed by Dr. Aguilar earlier. Thank you, Ma'am Angge, for sharing that hot off the press algorithm. So again, many doctors changed from in-person to telehealth visits, and sometimes not being able to examine the patient and do the diagnostic tests would cause a delay in not only in the treatment, but also firstly in the diagnosis. Okay. So what are now the strategies that we can employ to manage endometriosis in a pandemic? So while it can be frustrating and concerning to face delays and cancellations, staying in touch with the doctor or the specialist team is very important. So that's where telemedicine or teleconsult comes in. So it provides a very important conduit between the patient and health providers who can actually help these patients alleviate the number one symptom that they have, which is pain, of course. And then, of course, hopefully be able to manage the infertility part of having endometriosis. So what are the other things that can help a patient manage endometriosis during a pandemic. So dietary and lifestyle advice, prescriptions for pain and hormonal medications, and recommendations for complementary therapies would help a lot in managing endometriosis. So what can we tell our patients? Tell them to get enough sleep, do low intensity exercises like yoga, which can help with relaxation and managing pain. And then when symptoms are particularly painful, they can also use yung mga hot water bottles, warm baths, over the counter pain relievers, no, like ibuprofen, which may help relieve the discomfort. Of course, you can advise them to get in touch with online support groups, which can help. Sometimes just talking about it can actually help alleviate the pain and the worry that comes with having endometriosis. And of course, you advise patients to keep a diary of their symptoms, no, so that when they are able to see their physicians, they're able to narrate or tell the physician what happened to them during the times that they were not able to see their doctor. So just a few lifestyle modification advice that we can give. So numerous studies have been conducted to establish the effect of lifestyle modifications on endometriosis and infertility at that. So we all know, as described by Dr. Aguilar, that endometriosis is an estrogen-dependent disease. This is actually a very inflammatory condition. So any lifestyle that reduce the production of estrogen may reduce the risk of endometriosis. And diet and lifestyle choice can have an effect on the magnitude of pain and the pace of progression. So various studies have shown that endometriosis may actually be more common in tall, lean women than in heavier women. And women with a BMI more than 30 generally have irregular cycles and may suffer from anovulatory cycles, which may actually reduce the risk of endometriosis. However, despite the discrepancies, it is thought that exercise reduces the risk of endometriosis. And women who started exercising at a younger age and exercise regularly, so this is about 2 hours per week, or I tell my patients to have exercise 30 minutes a day, or at least 3 times a week, no? So this may be explained by the fact that regular exercise lowers estrogen levels. Then what about food, no? So let's go to the endometriosis diet. So there are actually a lot of books that you can access even online, no? Which will help you know what kind of food to eat and what food to avoid. So again, what are the food that may help? So fibrous foods such as fruits, legumes, and vegetables. You have your iron-rich foods such as broccoli, beans, and nuts. Antioxidant-rich food like oranges, berries, and beets. And foods rich in essential fatty acids such as flax seeds and artichokes. So those suffering from endometriosis should reduce the consumption of trans fat. So what is trans fat? It's what we see in processed foods like potato chips, diba? Yung mga biscuits, no? And yung mga fries, no? Yung favorite nating French fries. So we should try to avoid this when we have endometriosis and increase our intake of omega-6, decrease the intake of omega-6 fats found in vegetable oils, which can increase uterus pain and inflammation, no? So these are the dangerous foods for endometriosis. So we should limit saturated foods. So what are the saturated fats? Bacon, sausage, egg yolks, avocado, high-fat processed snacks, such as cookies and pastries, no, which are all loaded with saturated fats. And of course, red meat. So meat, we should try to avoid not too much meat, no, intake. Of course, high-fat dairy products. So women with with endometriosis are discouraged to take high-fat dairy products such as whole milk, cream, and butter. And of course, caffeine-laden beverages. They say it causes also some sort of contraction, which can add to the pain, no? And of course, highly salted food like canned soup, pretzels, chips, dried foods, no, such as jerky. And of course, white food. So these would include white rice, pasta, white bread, cakes, and cookies. No? So as we can see, these foods are very inflammatory and can actually add to the pain caused by endometriosis. And of course, what are the other do's and don'ts? So we should minimize toxic food, food high with high glycemic index, maximize nutritious and hormone balancing food, maintain digestive alkaline acid balance, maximize consumption of raw food. So better yung mga fruits and vegetables, no? Because we barely cook them. Eliminate food allergens, optimize digestion, enhance the immune system by getting enough sleep and getting enough exercise. We should cleanse the body regularly, detoxify the body when needed, and lead a stress-free life. No? And so, my conclusion. So, as lectured by Dr. Aguilar, we know that it's a chronic and a recurrent condition. No? In fact, the only way that we would actually get rid of pelvic endometriosis is if we do total hysterectomy with bilateral salpingo-oophorectomy, which is not an option for very young patients, especially our adolescents, who actually suffer from a lot of pain and may have infertility in the long run, like the 41-year-old patient discussed by Dr. Aguilar. So it is a chronic and recurrent and a long-standing potential impact on reproductive potential, which requires specific expertise to appropriately counsel patients on how to optimize fertility. So our department has come up with a new division now under OBGYN. We have the Center for Endometriosis. We have just started the center, and hopefully this will help a lot of our patients, not only patients, but also healthcare workers who would actually deal with patients having endometriosis. So watch out for that. It's still in the works, but hopefully we will have it up and running soon, so that we will be able to serve more patients, especially the underserved. And then what are the recommendations? Other recommendations to treat endometriosis. So of course, you can advise your patients to try to get pregnant at an earlier age before spontaneous loss of ovarian reserve or surgical impact. And of course, the discussion of the risks and benefits of medical management. So sometimes we have to tell patients, get pregnant na, because the pregnancy itself will help temporize or at least prevent your endometriosis from getting worse. Of course, you should advise fertility preservation for patients who still do not have partners or those who have no plans of getting pregnant yet. And then maximize medical management and avoid surgery, because surgery may actually cause ovarian injury. Okay, and then of course the infertility patients, if warranted to undergo assisted reproductive technology, please tell them to consult with us so that we can manage them earlier. So with that, I would like to end my reaction to Dr. Aguilar's lecture. Thank you very much.
Thank you very much. That's Dr. GLADYS Tanangonan. I'm sorry, GLADYS, and to everybody, kasi I was caught unaware. I thought Raymond was going to talk. Walang battery yung computer ko. So anyway, GLADYS
No problem.
Tanangonan.
My connection got lost kanina, Dr. Susie, when I was about to speak, kaya medyo weird eh.
Wala rin. Ano tayo naninibago? O sige. Okay, so thank you so much, GLADYS and Angge. And we're going to ask you to open your videos because we're going to have a Q&A. I haven't seen any questions in the Q&A. So if you want to ask some questions, put them in now. But meanwhile, Raymond has, we have a public service announcement.
O sige na anak, parang kagat lang ng langgam. Kantik o yung kumikiliti lang. Ito naman parang hindi ka pa nababakunahan dati. Akala ko pa naman brave girl ka. Nakakahiya na kay Doc.
Okay lang po, nanay. Ay, ang cute naman ng shirt mo. Favorite color ko rin yan.
Doc, favorite ka rin po ang color nito. Pero ayaw ko po ng red hunting. Masakit kumagat at takot rin po ako sa blood. Magtutugo po ba ako sa bakuna?
Ah, hindi. Walang dugo sa bakuna. Konting pisil lang, tapos na.
Kakasugat ba ako, Dok?
Hindi ka magkakasugat. Lalagyan lang natin ng plaster pagkatapos para safe. Di ba nabakunahan ka na rin ng contra measles at chickenpox dati? Parang ganun lang din ang bakuna para sa COVID-19.
Natatakot pa rin ako, Dok.
Alam mo ang secret sa pagiging brave. Hindi ibig sabihin na wala kang kinatatakutan. Kundi, kahit natatakot ka, hinaharap mo pa rin ito.
Okay. Ready na po ako, Dok.
Una, pupunasan ko muna ng bulak na may alkohol ang braso mo. Okay? Tapos, mabilis lang na konting... Ayos! Tapos!
Tapos na, anak. Pwede mo nang buksan ang mga mata mo.
Nay, sabi sa inyo, brave girl na po ako eh.
O, heto ang prize para sa'yo, ha? Wow! Bagay sa shirt mo. That's the color of bravery.
Colorin yan for love.
Thank you, Doc. Thank you, Nay. Dahil ako po ay mahal ninyo, nagpabakuna na ako.
Kaya mga bata, magpabakuna na kayo.
Stay safe and stay well. Mga bata, magpasama na sa Bakuna Center. Thank you so much, TVUP. The COVID Communication Public Service Announcement is one of the many creative outputs of the Stop COVID-19 team to push for pediatric vaccination for children aged 5 to 17 years old. Please share this video clip with our social media accounts. Stay safe and stay well. Magpasama na po sa Bakuna Center. Okay, I think we can entertain questions already. Dr. Susie, let's start.
Yeah, okay. So there are some questions coming in now, but I was gonna ask kasi I have a classmate who, when she had her period, she couldn't even go to school. Sa sakit, nakahiga palagi. Later on in life, when she got married, nawala yung endometriosis niya. So maybe I'll ask Angeno to explain what happens during pregnancy na nakakatulong dun sa endometriosis.
Okay, thank you for that question. Indeed, primary dysmenorrhea is common among our adolescents and younger adults. And when the patient or the woman already gives birth or has a pregnancy, theoretically there is a reversal of the lesions that may have developed. But if it's just primary dysmenorrhea, sometimes a pregnancy may actually help solve or resolve those concerns. Mawawala na yung kanyang sakit, tapos hindi na siya magkakaroon ng future na sakit. But for some women who indeed have endometriosis, even after childbearing or when they pause for a longer period of time, the lesions grow back and endometriosis recurs or may become more florid compared with prior to when they had their menarche.
Thank you, Angge. Raymond, I think you've got some questions there. Okay, go ahead with the questions in the box.
So, what other conditions, I'm just reading it off the chat box po, no? What are conditions other than endometriosis that may cause similar pelvic pain or dysmenorrhea daw po?
Okay, thanks for the question. Of course, we have to rule out other syndromes. In other countries, IBS also can happen in inflammatory bowel disease, Crohn's disease, and that can mimic the chronic pelvic pain seen in endometriosis. You also have to rule out other pathology in the pelvic area, which includes your genitourinary tract. There could be stone or a urolithiasis. There also could be a diverticulitis that can mimic the pain of endometriosis. But sometimes it's the other way around. Interestingly, we have a lot of endometriosis patients na pagtingin mo, merong appendectomy scar. Because sometimes the pain of endometriosis is mistaken as acute appendicitis. Kaya parang marami sa kanila na operahan. But when EL and appendectomy happens, siyempre natanggal na endometriosis sila, babalik pa rin yung pain. Pero many of them, because of a trip to the emergency room, are diagnosed with acute appendicitis. So meron ding may vice versa effect din in terms of other differentials. Endometriosis may also be mistaken for other pelvic or gastrointestinal conditions.
Yeah, thank you, Angge. Gladys, I have a question here coming in for us from text. When you say have an early pregnancy, what age are we looking at?
So
How
siguro
old?
the reproductive age. So this would be ideally between 20 to 30.
Okay. So 20 to 30 is a good time na para magbuntis na. Pag after 30, mas mataas ba yung risk ng endometriosis?
Yes, because you've had more time to have your regular cycles, which should contribute to the worsening of your symptoms. Plus, the age factor comes in. So you would have the other complications of pregnancy when you get pregnant at a later age.
Ayun. Okay. In the Q&A box, Raymond, ayan na, 3 na.
Okay, well, yung isa po kasi nilagay niya na rin sa chat. So, I will have to dismiss that one. Question, but I think I find it interesting. What treatment options are available for Catholic patients who are not willing to take OCPs?
Thank you for that question. It's a valid concern, and we can address that one by providing medications such as progestin-only medications that can suppress the menstruation. Okay, so it depends on what the goal of the patient is. If the patient does not want to get pregnant, that's a contraceptive effect of the medication. But if the intent is just to suppress the pain, then hormonal medications may be resorted to. So I think that will be something that has to be discussed with the patient with regards to medication, the mechanism of action of which drugs, and what we can offer as alternatives.
There's another question, Raymond, from the Q&A.
Yes, okay. So this one comes from Chelsea. May I ask what could be the remedy if I always defecate or feel like defecating during the first and second day of my period and also experience menstrual pain?
That's a very good one of the common manifestations of deep infiltrating endometriosis. The endometrial implants are the back of the uterus and may go up to the rectosigmoid wall. So that's why we have the symptom called dyschezia or painful defecation. So of course, like what GLADYS said, maybe high fiber diet will facilitate relief of some of the symptoms, especially if the patient's constipated. But generally, if it's from DIE, then hormonal suppression with our usual medications can help solve that problem.
Okay, thank you. Raymond, let's go to our fun quiz questions.
Fun quiz question. Okay, can we have it on the screen, TVUP? Okay, so ito po medyo this is in the vernacular. Kung masakit po ang puson, kailan po dapat kumonsulta sa doktor? We'll ask Dr. GLADYS naman para she'll be the one to answer po. Dr. GLADYS?
Yeah. So any pain actually you should consult because you do not know what it is, and sometimes delaying consultation would actually delay diagnosis and treatment, no? So dun sa options natin, no, all of the above yan dapat. Kasi syempre, pag masakit habang nireregla, it's actually one of the common signs of having pelvic endometriosis. Hindi mabuntis, yan, napaka-common yan na manifestation also of endometriosis, no? A lot of our patients coming in for infertility consult would actually have endometriosis. And if you do not have that treated, you might have might take you a long time to get pregnant. Hindi tumitigil ang pagdurugo. So, Not necessarily endometriosis, but definitely pag hindi tumitigil ang pagdurugo, pwede kang kailangan ka mag-consult, no? So what would be some of the conditions that can cause the hindi tumitigil ang pagdurugo? So pwede kang may adenomyosis, which might manifest in the same way as endometriosis. It can cause chronic pelvic pain, and then plus the bleeding, no? Then you might also have a myoma, which might cause also infertility. And then of course, there's actually a bleeding that's also related to having endometriosis. This is when patients would have this brownish discharge before and after their cycle. So sometimes even intermenstrual, they would have these brownish discharge, which could be a sign of endometriosis. So for all of them, please do consult your OB, your doctor.
Yun, okay. For our second question po, namamana po ba ang endometriosis, Dr. Gladys?
Yes, I've seen patients na pati yung mothers nila, even mga kapatid nila, have endometriosis, no? So there might be a predisposition. Remember the table, the picture shown by Dr. Aguilar, no, of the different ways that you can actually develop endometriosis, and probably one of them would be the immunologic part, no, the inability of your body to clear out that retrograde menstruation, which causes endometriosis. So that's probably one of the things that you can actually manamana from your relatives who have endometriosis, which can make you predisposed to have the same condition.
Okay. Dr. Susie?
I have a question for Gladys, again coming in through my text, because you did talk about exercise and dysmenorrhea. Can you explain that a little bit more? Kasi yung paniwala noon ay dapat magpahinga ka, right? You shouldn't be so active if you're having dysmenorrhea. Can you explain that a little bit more?
Okay, so with exercise, sometimes you release happy hormones, di ba? Yung mga endorphins natin, which can actually help you manage pain, no? At the same time, particularly relaxation exercises like yoga can help actually alleviate the pain, no? So we know how those yoga masters would actually encourage us to undergo yoga so that we will be able to manage not only pain but also the stress that comes with having endometriosis, no? So basically, that's how exercise would help alleviate the symptoms of
Dapat
endometriosis.
mag-exercise. I think that's the advice, no? You should be doing light exercise even if you have dysmenorrhea. Oo. Kasi yung nauso nun, higa ka lang. Diba, higa mo na lang hanggang mawala. No? So ito sinasabi, you should be active and you should be moving a little bit more. Okay, I think Gladys, you were the one who mentioned the Center for Endometriosis. Can you tell us a little bit more about that? Because I recall Stella was telling us na parang ang daming kumukonsulta for endometriosis. Tell us a little bit more about the proposed center.
Yeah, so this is composed of the different, not only REI, no, the different subspecs of OBGYN, no? So this would be supposedly a center for excellence for treating endometriosis. So under that division, we would conduct research. We would hopefully be able to give timely and provide timely diagnosis and treatment to our patients, which are evidence-based and hopefully affordable for our patients, because we are hoping to target our underserved patients who really need much help, no? So also we would like to use it as a conduit to educate not only doctors but also the other healthcare providers that can actually help patients not only in the clinics but also, let's say, for lifestyle modification, also like the nutritionists, the researchers, no? So it's going to be a center for excellence for the treatment of endometriosis.
Nice. Okay, really very good. Raymond, do you have any more questions with you?
I have two more questions. Pero
Sige.
ako, I personally find it interesting that these are being asked po. Na first question for Mamangge. Yung pagkain po ba ng maasim na pagkain while menstruating, is it true? Totoo po ba yan?
It is a common practice, di ba? Narinig ko na rin yun. but there is no known connection. Maybe there's relief when you eat comfort foods. Baka sa Pilipino, 'di ba, tayo maasim ang ating comfort food eh. Kaya baka that helps the well-being of the individual. But acidic food, di siguro, no? Siguro mas gusto ko nga kumain ng sinigang na maraming gulay, gaya nga ng sabi ni Gladys, that helps. But otherwise, wala pa kami na-establish na connection whether the relief is effective or not.
Effective. Okay, thank you.
Man,
Thank you,
meron
Ma'am
pang isa
Angge.
sa Q&A. Meron pa sa Q&A na tanong.
Okay, ito naman po. Does glutathione, vitamin C, and vitamin E, do all those help lower the chances of getting endometriosis?
I don't think there are specific studies linking those, no? But basically, I think those are antioxidants and anti-inflammatory agents, which you may also take, no, if you wish to take them, but do not expect that they will cure endometriosis, no? So there's really treatment for that. And all the things that I mentioned, even the dietary changes that you can employ, no, they are not the cure for endometriosis. So it's important to still consult your doctor, but of course you can use all those supplements as an adjunct to the treatment of endometriosis.
Okay.
Okay. Do you have
Thank
any
you,
more
Dr.
questions,
Gladys.
Raymond?
One final question. This one is more of experiential naman po. I had a classmate before, when she has her period, she always passes out. Regular daw po yung pagkakahimatay. So akala po nila mahirapan daw po siyang mabuntis, pero nakabuo naman daw po kaagad. So bakit daw po kaya may ganong association na nahihimatay kapag nagkakaroon po ng period, Ma'am Angge?
Alam mo, yung syncope, they may actually be suffering long-term chronic pelvic pain. And the pain is real. Minsan, it's a pity that many of us minimize or normalize chronic pelvic pain among women. Kasi sabihin natin, it's part of our womanhood, it's part of growing up. Dapat po maaga natin na-recognize, and this is not normal. There should be evaluation and early management. We don't want to have these women suffer for a long period of time. Interestingly, I have a patient who was a physician, and she had an evaluation in her late 30s. I put her on very effective long-term medication, and she said, "My God, doktora, for the first time in my life, there was relief." So imagine, she was there, decades suffering. Doktor na siya, hindi pa niya na-realize na there is a better way of going through your periods, better quality of life, as long as you're able to access appropriate management. So yung normalization ng all of this symptomatology, pelvic pain, nahihimatay, absent, yung absenteeism, nakalib sa trabaho, there is a solution. First, evaluation, and then if it's necessary, then we manage the pain as early on. So we don't lose out on what we can contribute to the society, on what life has to offer for us. I think that will be my take-home message for this. And the technology, the care is available locally.
Hindi dapat magtiis, ano? Kasi parang tinitiis, sinasabing, part talaga. May isa pang question lang ba dito, Raymond? If
which one? Saan po?
mag-experience po ng second time of pagtatae, first day sa mens, then masakit din yung puson, ito po ba ay normal?
Yung diarrhea.
2 times of diarrhea on the first day.
Diarrhea, no? Oo.
And then
Well,
pain on the second day.
Baka yung diarrhea, it's a common, not naman common, it's an effect of progesterone withdrawal. Kasi at the end of our menstrual cycle, progesterone is withdrawn. Babagsak yung level ng progesterone natin. Because after ovulation, we have high progesterone. At that stage of our menstrual cycle, constipated naman tayo because progesterone is known to decrease gastrointestinal or intestinal motility. Pag withdraw nun, ma-release yung control ng inyong intestinal motility, diarrhea na maabutin. But for this patient, medyo exaggerated, baka very wild yung fluctuation ng hormones niya. And apart from that, may pain. So there's another one that we may want to have evaluated, not just the diarrhea but also the pain. And baka nga may DIE din yan.
Okay, so kailangan kumonsulta na. Ang pag-inom daw po ng soft drinks will lessen the pain sa puson. GLADYS, siguro sa'yo to.
Actually, nung high school ako, inisip ko yan, no? When I drink, malakas kasi yung menses ko, no? So it's basically more of that. It's more of the caffeine intake, actually. It will help na parang lumabas, di ba, lalakas yung menses mo, tas mas mabilis slough off yung endometrium, no? But really, no correlation. So I guess it's just the caffeine effect of taking the soft drinks.
Ayun. Okay. So, any more
I
questions
think
on
that's
your
the
end,
last one,
Raymond?
Dr. Susie. That's the last one.
Sige. Okay, so we're going to give our panelists a few moments to construct their parting words for our audience.
Message to the audience. Sige po.
So just a few words, message to the audience. While you're thinking about that, we're going to run our evaluation for the webinar. Go ahead, Raymond.
Thank you so much, Dr. Susie. Can we have it flashed on the screen? So for our evaluation po, we usually have this 5-question survey. It's a 4-point Likert scale. And we invite everyone. Wala po kaming hiwalay na sinisend out na evaluation poll. Ito na po iyon. So please participate po if you can. And we will be very appreciative. Very, very helpful din po ito as we gather more and more feedback, especially on topics in the future din po. Number 1, the panelists demonstrated thorough knowledge of the topic. The panelists were well prepared and organized. Number 3, the panelists spoke clearly and audibly. Number 4, the panelists used appropriate language with technical medical jargons adequately explained. And number 5, the panelists contributed to new perspectives and knowledge on managing various key health issues. We will not be closing this evaluation poll until the very end of this webinar as we move on to the final messages from our speakers. Dr. Susie?
Okay, thank you. GLADYS, ikaw muna.
Yeah, so thank you everyone for watching today's session. No? So what's my final take on pelvic endometriosis? It is a chronic debilitating disease which can affect a lot of women, no? Not only presenting as pelvic pain, but also presenting as infertility. It can be a very baffling condition for some physicians because it can mimic a lot of conditions. It can look like cancer, it can look like TB, no? So please do not forget to consult your doctors. Pandemic or not, it's very important that you consult your physician so that you can be guided, so that you can be diagnosed early, especially for our younger patients. No? Remember, you will be suffering endometriosis for a long time, and it can cause infertility. So it's very valuable that you consult your doctor so that you can be guided accordingly as to the treatment. Thank you.
Thank you very much, Dr. GLADYS. We'll go to Dr. Aguilar. Angge, ikaw naman.
Thank you. Okay, this is a great opportunity. It is our personal as well as organizational advocacy to make sure that endometriosis has increased awareness among our women. It's understood by the women who suffer and for their caregivers, and also for the medical and health community to be able to recognize and appropriately manage them. We will not tire of conducting all of these explanatory lectures, lay fora. Please invite us. We have a whole group of speakers that will be able to address the awareness needs, and we also have a group of specialists who will be able to provide appropriate care for this. So wag pong magtiis, gaya nga ng sabi ni Ma'am Susie, mayroon pong solusyon. Tutulungan po namin kayo, nandito po kami. Thank you.
Thank you so much. It's Dr. Aguilar, again from the Philippine General Hospital. Okay, we have our closing remarks from Dr. Stella Jose, who is the head of the Expanded Education and Training Office of UP PGH. And thank you, Stella, for putting together this panel. Si Stella lang may pakana nito, and we agreed it's a good topic to start the year. So Stella, over to you.
Good afternoon, everyone. Thank you to our speakers, both excellent lectures from Dr. Angela Aguilar and Dr. GLADYS TANANGONAN. From the talk of Dr. Aguilar, she mentioned the two types of endometriosis. You have the superficial endometriosis and the deeply infiltrating endometriosis. And this is the DIE, or what we call deeply infiltrating endometriosis, is the one that causes rectal pain. No, it happens when you have when you have sexual intercourse or during your menstruation. You have diarrhea. That is the cause of that. And she mentioned the genetic predisposition. So there is that epigenetic theory. I suggest we all go back to the lecture. And yung question, namamana ba? Ang answer ay yes. So there's a genetic predisposition to this. And she also mentioned retrograde menstruation. So menstruation does not come out from the vagina, but through the fallopian tube. This is deposited in the serosa of the uterus. Now, the clinical diagnosis of endometriosis is emphasized. She said that symptomatology is important. The physical examination, you have to do your pelvic examination, as well as a rectovaginal examination, and the imaging techniques. So, unlike before that you have to operate on the patient to make the diagnosis, it's not like that now. It is more of the clinical symptoms of the patient. Now, she mentioned about tumor markers. These are very important markers because it will determine if what the patient has, the ovarian mass, is malignant or benign. And we use the CA125, the HE4, and the ROMA scoring. The ROMA scoring is the combination of CA125 if the patient is menopausal and the ultrasound findings. And the score of 4.2, as mentioned, gives you a low risk for an ovarian malignancy. Now, for Dr. GLADYS TANANGONAN, very interesting also, and also an excellent lecture. And she mentioned that endometriosis increases the susceptibility to COVID-19. No, that's the question for her. And she said that endometriosis does not increase susceptibility to COVID-19 infection, but alters the manifestation of the disease. I think that's very understandable because when you have the COVID-19, your mind is always you think that the endometriosis is related to whatever pain that you're having, but really it doesn't make you susceptible to COVID-19 infection. And she mentioned the preventive measures and the management for them. And she said also that telemedicine is an important conduit with patients. So patients should not be shy or hesitant to do teleconsultation. And what is important is the preventive measures such as the diet. No? So our diet must be more of vegetables, no? Lesser of the fatty food, no? And we should exercise we should have regular physical activity, and we should in our habits we should eliminate the use of tobacco, of smoking and caffeine, no? And the use of supplements because they decrease the inflammatory markers. You can also use supplements, but the real management is hormonal therapy. No, so it was mentioned also by Dr. Aguilar. No, so you can use oral contraceptive pills or other hormonal therapies such as Dynagest. No? And the management, as mentioned by Dr. GLADYS, is you can use heat compress, massage, and acupuncture. So as to the question of counseling, there should be appropriate counseling to the patient. And she mentioned pregnancy at an early age. So what she meant was from age 20 to 30 years old. She didn't mean that, like teenagers. So, and she also mentioned maximize the medical management. And if the patient really has a difficult time to get pregnant, you should consider IVF or in vitro fertilization for this patient. By the way, PGH will have an in vitro fertilization center in the near future. So the building is already being built, and one floor of that will be the IVF center of PGH. Now, she also mentioned about oocyte or ovarian tissue cryopreservation. So, for example, a woman has endometriosis, it is good to save your oocytes while the ovaries are not yet damaged. And so this oocyte, they are preserved and you can still have a baby afterwards. Over to you, Susie. Thank you for your attention.
Okay, thank you so much, Stella, for that excellent summary. And we like to thank our guests also for your time and for putting together your excellent presentations. You'll see the gratitude of our audience na nagpapasalamat. Marami daw silang natutunan. Okay, so next week, okay, here we go. The dominant COVID-19 variant is still Omicron, okay? But in the US, XBB 1.5 is now responsible for about 30% of cases and rapidly becoming the most dominant type of Omicron in the US. There was some news, I think, in late December that the variant in China was called BF7. And so we here at Stop COVID Deaths are not, what should I say? We're not letting our guard down on watching what's happening in terms of the pandemic. Hindi pa tapos eh. No, ang dami pang nangyayari. So next week, don't miss this. We will talk about Omicron subvariant XBB 1.5. And we will have infectious disease expert, and we'll also try to see what's the dominant strain in the Philippines. So we're not letting go of the topic of COVID. We're going back to hardcore COVID next week. So, invite your friends, those who are interested in this, because we'll have some experts talking about it. Raymond, over to you.
Thank you, Dr. Susie. I'm not sure if everyone knows. It's called the Kraken. Yun po ang kaniyang
Kraken,
XBB on that 5. So yun po ang, and hopefully we'll learn more from our invited speakers. Dr. Saloma of the Philippine Genome Center will be one of those speakers po. In front of you is displayed the evaluation poll. So we see that at least 92% of those who participated indicated that they strongly agree with all of the questions po. So maraming statements. Maraming salamat po sa inyong lahat. And we really look forward each and every week to your participation in our not just credible online community, but in all of our activities po dito. But before we conclude our program, we'd like to let you know that all Stop COVID Deaths webinars are archived for viewing at the TVUP YouTube channel for your convenience. Just go to www.youtube.com/TVUP and we'll be able to TVUPPH, and we'll be able to make sure that that's something that hopefully will be worthwhile. And especially meron po tayong mga shorts na tinatawag po, something that's very, very much consumable. We have those are selected presentations featured na maikli lang po, whether you're maybe in the train, in the bus, you're commuting, o nagpapahinga lang po, nagpapaantok, something that will be helpful for you. It's also in the YouTube channel po of TVUP, youtube.com/TVUP. So this formally closes our webinar for the week. Magkita-kita po tayo again next Friday po from 12 noon to 2 p.m. It's a day.
Together we can stop COVID deaths.
So keep safe, keep healthy, and see you online.